You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for February 24, 2023. This week, reporting about fraud in medicine, AFib, stroke, a possible new cholesterol-lowering drug, and the tone of debate in medical science. First topic today is that you may have seen a sweeping ProPublica investigation into overuse of peripheral artery procedures at the Wichita VA. The case became public because of a whistleblower, and Medscape Medical News has also published a version of the piece. The evidence presented thus far is worrisome. That a VA hospital in Wichita, Kansas had more expenses for vascular products than the top 10 VA hospitals combined is highly worrisome. There were records of meals and Apple products and NASCAR tickets from device reps to doctors doing these interventions. And according to internal emails, an ecological finding was that amputations increased over the time period from about 6 in 2013 to 38 in 2018. And amputation data fits with the premise that there were too many percutaneous interventions. Our vascular surgeons have drilled into my head that when it comes to peripheral interventions in the legs for claudication, less is 1,000 times more. You can improve symptoms transiently with a peripheral balloon or stent, but late amputation risk goes way up. I really enjoy speaking with our vascular surgery team because even more than us, they promote exercise, smoking discontinuation. They say when a calf hurts, walk some more. Okay, comments on this difficult story. First and foremost, one of the foundations of this country and one that cannot be understated is due process. These are allegations and the case is ongoing. If allegations can convict, we are doomed. But there clearly have been doctors and hospitals guilty of fraudulent behavior similar to those alleged in this case. It's sad when it happens. My thoughts on such cases are, yes, of course, it is important to bring them out in the open, adjudicate them fairly, and punish the guilty. But it would be a mistake to think that outlier cases are representative of all the good or bad parts of medicine. First, the good. Neither ProPublica nor New York Times or any other news organizations can cover the vast amount of good that doctors, APCs, nurses do each day. I mean, even when we can't cure, the amount of caring that happens as a regular matter never makes the news. I liken it to anticoagulants and AFib. No one checks in the emergency department in the middle of the night to announce that they have not had a stroke. I mean, if ProPublica followed a hospitalist or primary care doc or a cardiologist around for a few days, what story could they write? Dr. Smith tries her best to help the sick patients under her charge. She succeeds a lot, but not always. She often works through lunch and worries about getting her kids picked up on time. No one buys her Apple products. A news story without a chapter with an industry rep buying NASCAR tickets and steak dinners just means no attention or clicks. Now a word on how these Three Sigma stories don't represent the vast amounts of low-value care, even harmful care, that populates the middle of the bell curve in medicine. This is my biggest criticism. The outlier cases don't do justice to the everyday, banal nonsense that is codified as therapeutic fashion. Some examples. In cardiology, we burn money in our search for ischemia. Nuclear cameras run like printing presses at a mint. You have a twinge of chest pain lasting seconds, you get a nuclear stress. You have AFib, you get a nuclear stress. You have a run of non-sustained VT on a pacer telemetry, stress test. Not only do these tests make big dollars themselves, they feed downstream testing, coronary angiography, and stents. And once a stent goes in, you have a patient for life. And look, I picked on stress testing, but I see the same downstream cascade with echo testing too. Someday, regulators will cut nuclear scans, and you watch them plummet in popularity. Another example, coronary artery calcium scans. The experts say use them only to help with statin decisions. Yeah, right. In real life, these are tickets to the fast train of stress tests, CAS, and stents. Healthy people made into patients and then sources of revenue. And don't even get me started on screening. In the Nordic RCT of colonoscopy in 85,000 patients, the risk of death from any cause was 11.03% in the invited group and 11.04% in the control arm. And even if you defy statistical principles, like the GI professional societies urge you to do, and look at the as-treated patients in that trial, the risk of death from colon cancer goes from 0.3% to 0.15%. Yet nothing changed. Discussion of less expensive screening tools, not promoted. Discussion of the ludicrousness of trying to prevent death from one of thousands of diseases, definitely not allowed. The GI professional societies had talking points on the null trial within days. Now, I could go on for many minutes chronicling all the low-value care and harm that sits in the middle of the curve of medical practice. But again, news organizations can't do stories like that. They're just too simple and banal. And too problematic, right? They'd be labeled as cranks or promoters of misinformation if they tried to convince Americans that much of the care that they receive is low in value or potentially harmful. Okay, second topic, speaking of low-value care, let's do some more on AF monitoring and stroke. I'm moderating a session on AF screening here at the Western AFib conference in Park City tomorrow, so screening is on my mind. And I missed an important study on AF monitoring and stroke that came out about 6 months ago in JAMA Neurology. I got thinking about this study and this issue because 2 weeks ago, I covered a subset of the Stroke AF study, which was first published in JAMA in 2021. Stroke AF was an RCT in nearly 500 patients who had stroke from large or small vessel atherosclerosis. So these are patients who normally would get antiplatelet and statin therapy. In Stroke AFib, one group was randomized to a loop recorder made by Medtronic, one group got usual care. The primary endpoint was detection of AFib lasting more than 30 seconds. And with absolutely zero surprise, AFib was detected 7x more often in those who had the always-on implantable loop recorder. And at this month's ISC, International Stroke Congress, we learned data on the 3-year follow-up from Stroke AFib, and recall that Stroke AFib enrolled patients who had a mean chance VAS score of 5 in the atherosclerotic-related stroke. And after 3 years of monitoring in that trial, the rate of detected AFib had risen to 21.7% in the IL arm versus only 2.4% in the control arm. The senior author said in that news story that this shows that 30 days of monitoring with an external patch is not sufficient to exclude the presence of AFib, and this really argues for a strategy of immediate insertion of cardiac monitor placement if your goal is to look for AFib. Now, we should recall that the monitor he is urging use of costs up to $10,000, and patients incur a monitoring fee every 30 days. Now, this is where low-value care comes in. And remember what I said about most of the waste sits in the middle of the bell curve, which will not attract the likes of ProPublica. The core problem with detecting AFib in patients who've had a stroke due to atherosclerosis is no one knows what to do with it. Okay, now to the study I missed in August of last year. This is yet another paper from the prolific group in Copenhagen, first author Soren Didriksen. These were the authors of the LOOP trial. And JAMA Neurology published this post hoc analysis of LOOP where the two goals were to A, assess the stroke characteristics in patients who had a loop recorder for screening versus usual care, and B, assess the benefits of screening the highest risk patients, those who had had a prior stroke, before beginning a loop trial. I mention this analysis because it's similar to Stroke AFib, and it bears on the counterintuitive notion of AF screening. First, just 2 sentences on the main loop trial because we discussed it a lot. Loop was an RCT of AF screening with an ILR, implantable loop recorder, versus standard care in 6,000 patients who did not have AFib but did have high-risk features. And Loop found no statistical differences in the primary outcome of stroke nor secondary outcome of major bleeding, basically a wash. In this post hoc analysis, Dietrichson and his colleagues looked at the main outcome of adjudicated stroke according to severity, the modified ranking scale, and strokes with an MRS score of over 3 were the cutoff for severe or disabling stroke. They also took advantage of the fact that in the main Loop trial, both the implantable loop recorder and control arm had about 17% of patients who had had a history of prior stroke. Remember, patients in Loop had no AFib, so this was unlikely to be an AFib-related stroke. And so the total stroke count of the trial of 6,000 patients was 315, so they had 315 events to work with. That was about 5.2% of the patients. In the primary trial, the stroke rates were 5.5% versus 4.4% in the usual care arm, and that 20% lower rate in the screening arm did not meet statistical significance. The main findings of this post hoc analysis on the types of stroke were the following. There were 4 main points. First, 1 in 3 strokes were classified as severe or disabling, and there were no significant differences in either the ILR or control arm. Although we should note that the hazard ratio was 0.69 in favor of the screening arm, and that's a 31% reduction. The problem is that the confidence intervals are wide because we're looking at a subset of the primary endpoint. Hence, there's low power and there's more chance of picking up noise. Second main finding, the vast majority of strokes were ischemic. The most common, though, were small vessel strokes, not AFib-related strokes. Third main point, subgroup analysis that looked at the severe strokes in patients who've had a history of prior stroke found something interesting. There was a bit of a heterogeneous effect. Whereas screening had no effect on reducing severe stroke in those who had had a prior stroke, there was a significant reduction of severe stroke incidence in the screening arm in patients without a history of stroke. And they also found similar trends in these heterogeneous effects for screening in patients with prior or no prior stroke for ischemic strokes and embolic strokes, though those numbers were even smaller. That's interesting. We have to be careful, though, with subgroup comparisons, even when looking in the main trial. But this is a subgroup analysis of a post-hoc study. Numbers are low and noise is possible. But, these are plausible findings, right? Why would picking up AFib not benefit those who had had a prior stroke, which was likely due to non-AF reasons? And I think it's 2 forces coming together. One force is that older patients like those in Loop, who had positive risk factors but no AFib, have many reasons to have a recurrent stroke. So, competing causes of stroke is going to be one force. Now, the other force is an implantable loop recorder like a smartwatch or smartphone will pick up short-duration, low-burden AFib. Who knows what that means? Who knows what the normal range is for an average 75-year-old person who has risk factors? We've never monitored these people like this before. The authors are careful in their words, and you should read the entire paper, but here is a sentence that stuck out for me. Quote, albeit not designed to investigate post-stroke regimens, the current study does not support ILR screening for AFib among patients with a history of stroke. Wow, I don't know about your shop, but at ours there are lots of loop recorders going in for the screening purposes in patients who have had a stroke. Now, I'm not saying that every use of an implantable loop recorder is low in value, but I want to make the case that studies like Crystal AF, Stroke AF, that report more monitoring means more AFib and more anticoagulation may or may not help patients. For this, we need more data. Okay, the third topic today is a little bit on ACC coming up. ACC will start next Saturday. In next Friday's podcast, I'll offer a more extensive preview. And this week, I'll also post my choice for the top 5 trials as a column on the heart.org Medscape Cardiology. Now, of course, that column is always wild and biased guesses. But since many of you may not listen to the podcast until ACC starts, I thought that today I would discuss one of the biggest stories from ACC, for sure, one that will come out on the first day early in the morning on Saturday. The trial is called CLEAR Outcomes, and it is a classic cardiac outcomes trial of the lipid-lowering drug bempedoic acid. I know this will be a big deal because the company that makes the drug, Esperion, announced in a press release that the trial, with its 14,000 statin-intolerant patients, met its primary endpoint of first occurrence of CV death, MI, stroke, or coronary revascularization. Some quick background. Bempedoic acid is a once-daily oral prodrug that is activated in the liver, and it inhibits action of ATP citrate lyase, which acts upstream from HMG-CoA reductase, a molecule blocked by statins. As with statin treatment, bempedoic acid reduces hepatic cholesterol synthesis, and it results in upregulation of LDL receptors on the hepatocyte surface, which then enhances clearance of LDL cholesterol from the systemic circulation. Now, I'll link to the rationale and protocol paper of the CLEAR Outcomes trial. I learned there that CLEAR Outcomes is one of at least 9 trials for this drug. A New England Journal of Medicine published one of these called CLEAR Harmony trial, which was a 1-year RCT of bempedoic acid versus placebo in about 2,000 patients with heart disease or heterozygous familial hyperlipidemia. Patients had to be on maximally tolerated statins and have an LDL cholesterol greater than 70. CLEAR Harmony found that the drug did not lead to a higher incidence of overall or serious adverse effects, and it led to a lower LDL levels. The trial was not powered for outcomes, though they were numerically less in the bempedoic acid group. JAMA has published a CLEAR Wisdom trial. This was also a short trial in 700 patients, which also showed that the drug reduced LDL cholesterol by a statistically significant 18% over placebo. Again, the trial could not say anything about outcomes. And both trials found no differences overall in adverse effects. Bempedoic acid seems not to cause myalgias, but it does increase uric acid levels, and gout occurs more often in the bempedoic acid arm. Now, CLEAR Outcomes, which will be presented at ACC, enrolled patients who had established vascular disease or high risk for vascular disease and statin intolerance and an LDL greater than 100 milligrams per deciliter. The mean age of patients was 65 years. The mean LDL cholesterol of the enrolled patients was 139. I get that from the rationale paper. At ACC, we're going to have our critical appraisal hats on, right? CLEAR Outcomes was positive. We know that. Bempedoic acid met statistical significance for lowering major adverse cardiac events in statin-intolerant patients. But here are some of the big questions that I'll have. Was the result statistically robust? What were the confidence intervals like? You hope the upper bound was not close to 1.00 or no effect. Was the result clinically significant? You hope for a statin-like effect of possibly 25% relative risk reduction. And you hope that any relative risk reduction translates into a substantial absolute risk reduction. I mean, if an expensive new drug reduces the risk of a non-fatal cardiac event of 1%, well, that's going to be a harder sell. But perhaps the most important question will be what the authors say about statin intolerance. Now, the authors define it this way, quote, statin intolerance has started or increased during statin therapy and resolved or improved when statins were discontinued, resulting in an inability to tolerate either A, 2 or more statins at any dose, or 1 statin at any dose and unwilling to attempt a second statin or advised by a physician not to attempt a second statin. My friends, statin intolerance is a real quagmire. And it's a place where I am sure this drug company sees a potential gold mine, right? Here's my take. On the one hand, all of us see patients that are absolutely convinced that they feel bad because of statins. But scientifically, we know that in blinded trials, the rate of statin discontinuation does not differ from placebo. And then there is one of my favorite studies of all time, SAMSON. Here, James Howard and colleagues at Imperial College London enrolled 100 statin-intolerant patients into a 12-month N-of-1 trial in which these patients spent 1 month taking a statin or taking a statin placebo or taking no tablets. Patients recorded symptoms every day on their phone, and you all probably know the results, but if you don't, sit down. Patients felt best during the no-tablet months, but they had nearly the same symptoms during the months they took the statins or statin placebo. In other words, statins definitely cause side effects, but it's not the statin chemical. It's merely the act of taking the statin tablet. After the trial, half of the statin-intolerant patients were successfully able to restart the drugs. Now, the editorial of the Sampson paper was titled, quote, "That myalgia of yours is not from statin intolerance," end quote. Therefore, in summary, organically or scientifically speaking, true statin intolerance is rare. You'd hardly have enough patients to enroll if you just used the science of it. But I, like you, see patients, and it's hard to discuss Sampson in an office visit. Patients are convinced that the drugs cause problems and they're not going to take them. So, in practically speaking, there is statin intolerance out there in the real world. Okay, final topic today, a short one. The technique of critical appraisal amongst evidence-based medicine advocates. Medscape Oncology has published an interesting editorial from Dr. Ravi Parekh. It's titled, "Why Evidence-Based Medicine Enthusiasts Could Use a Lesson in Persuasion." I would encourage everyone to read it. The way to communicate critical appraisal is something that I struggle with. Dr. Parekh tells a story which centers on an invited speaker who disagreed with his views on the use of observational studies. And what could be more relevant than the debate about observational studies? Parekh sees value in these studies. An unnamed speaker did not, and he said so strongly. In his essay, Parekh then launched into an argument against what he felt was a too aggressive approach to critique. Quote, "There is little nuance to these takedowns. The tone is too vitriolic, and frankly, many of these individuals would probably prefer to tweet or release a podcast rather than pick up the phone and call investigators or policymakers to describe their views." In short, Parekh goes on, the modern evidence-based oncology movement has succeeded in bringing awareness to the perils of observational data, surrogate endpoints, and faulty control arms, which is a good thing. And my friends, you could say the same thing about cardiology evidence base. We have observational data, surrogate endpoints, and faulty control arms. And Parekh goes on, but the delivery of the message has come at a price. It has created division among researchers, policymakers, and patients, and ultimately may be harmful to patients. One of Parekh's recommendations in his essay was to use more pathos or appeal to emotion. He recommended telling more stories of patients harmed by low-value therapies. This, he believes, would be more persuasive rather than the searing use of logos or logic. Seriously, you should read the piece. Sanjay Kaul on Twitter called it thoughtful and nuanced. And we should all be surely listening to Sanjay Kaul. For me, though, I disagree with many of these arguments. While I am all for being respectful, and I try to avoid personal critiques, I believe poorly done science with inappropriate conclusions deserves strong and clear rebuke. I mean, society and patients are harmed when medical science allows for low value or harmful care. Look, tone is overrated. Science that is spun can have devastating effects on patient care. In my opinion, scientists ought to be a bit more resilient and open to debate. The panels of cheerleaders at late-breaking trials really bugs me, for instance. It's why I like social media. And sure, social media has bad critiques, bad ideas, mean people. But where else can people go to get something other than the bland editorials in journals, the friendly talks at meetings, and podcasts from professional societies? So, in sum, with all its blemishes, I like the freedom of the open online digital space. And I know this is controversial, so let me know what you think. I am interested. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating on whatever podcast app you use, maybe a 1 or 2 sentence review. These things go a long way to helping others find us. Until next week and an ACC preview, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.